Bonjour. I'm indeed honored to be here today to be presenting with sort of pioneers of early intervention in various parts of the world. I'm sorry I'll be doing my presentation in English, but I can certainly take questions in French after. It's not perfect, but it's getting there. I've lived for the last few years in Quebec, and I can tell from the comments that I've been receiving since yesterday that the French is very different. So first I'd like to begin by thanking Dr. Krebs and the conference organizers for inviting me here today. We have about 20 minutes together, and I'm going to try and stick to the time because we're running behind schedule. What I had hoped to do in these 20 minutes is perhaps take the first little while to paint a little bit of the portrait of the Canadian perspective on early intervention for psychosis, primarily talking about the clinical and research work that we have done in the prevention and early intervention program for psychosis, which is a specialized early intervention program and one of the leading programs for early psychosis in Canada, and a program that I've been intimately involved in for the last 10 years. I'll also talk very briefly about a subservice of this program that tries to address the needs of young people who are at high risk for developing psychosis. And just before ending, just to talk a little bit about the future, both in terms of the future of early intervention for psychosis, but also the future in terms of better addressing the mental health needs of all young people in need. So, I think it's very hard to follow a talk by Pat because he kind of really presents the entire picture and brings that kind of history and experience that I can only sort of be inspired by. In Canada, early intervention for psychosis has a very long history and it has deep roots. And what you see here are two papers that Ashok Malla, my mentor and a very close colleague, wrote in 1999 and 2001, sort of making the case for early intervention for psychosis and also describing this concept of treatment delay and why it's important to pay attention to treatment delay before psychosis. And it's around the same time that he and others like Pat were getting together to move forward this cause of early intervention services for psychosis. As I mentioned earlier, I'm going to primarily be talking to you about work that we've done in the PEPP program, and I thought it would be helpful to briefly describe the service and the context so that you can situate what I present later within that context. So the PEPP service is an integrated clinical research program that serves persons aged 14 to 35 with first episode psychosis. It's the only early intervention service in its catchment area in southwest Montreal, which is an urban context, and it serves a population of about 400,000 people. It is part of Quebec's public health care system, so there's lots of sort of similarities. Whenever we talk about early intervention and sort of getting back to basics, we talk about two components, and we were talking about this last evening. The first component being strategies or interventions to reduce treatment delay, or what we call duration of untreated psychosis. And the second component being once somebody has been detected and has entered a service, offering them really youth-friendly, comprehensive, intensive, phase-specific treatment that is optimistic and focuses on recovery. And not all early intervention services for psychosis have both these components. Some have just one. And in the case of PEPP, we've been fortunate to be able to integrate both these components. So in terms of sort of reducing delay, a part of the rationale was presented earlier by Pat, and I'm not going to be able to go into detail, but a large part of the rationale for early intervention services for psychosis has been this idea of both that there is a critical period and that if you have treatment delays, they can have incredible negative consequences, both in terms of clinical outcomes, but also because people are young, there can be major impact on their work, school, relationships, family relations, and therefore treatment delay is something that you really want to pay attention to and reduce. The other sort of thing that sometimes gets missed, in addition to reducing treatment delay for its negative consequences, is the idea of making sure that a young person's help-seeking journey is not complicated, long, circuitous, and traumatic. So this idea that for many people with psychosis, this probably is their first entry into mental health care, and you want to try and make it as soft a landing into mental health care as possible. So with respect to trying to reduce treatment delays and creating these simpler, more friendly, engaging, direct pathways into care, what have we done as a service? One of the things that I think that we've done and we're very proud of, because it does set us apart from even many other early intervention services, is the creation of this rapid response intake system, which has some key features. The first being, we have an open, direct referral system. What that means is that anyone can refer a young person with psychosis, a family member, a teacher, a counselor, and there are no steps, no forms, no administrative requirements, no need to first go to your general practitioner or your pediatrician or primary healthcare physician. So essentially, it's direct entry to anyone seeking services. We also have a guaranteed quick response protocol. What that means is that anyone seeking help is guaranteed a response within 72 hours. And part of what we've done to create capacity for this is always having one or two very well-trained, engaging intake clinicians who are capable of being engaging, flexible, and at the same time assessing needs and matching the people to appropriate services. Along with this, what we've done, and we've spent a lot of time doing it because it needs consistent work, is creating and maintaining strong linkages with all potential referral sources in our catchment, be it the school or the primary healthcare system or the local emergency room or inpatient service. Perhaps what you'll see as a theme or thread running through many of the presentations today, and what I think has helped move forward early intervention services for psychosis, is this integration of research and evaluation into services and care. And what we've done at PEPP is similarly, everyone we've followed, we've always done sort of systematic evaluation of outcomes, of clinical predictors. We also do what we call are like these semi-structured interviews, really trying to trace the entire path or help-seeking journey that the person took before they entered our service. So what you can see over here is some of that work. What you notice typically is that once somebody has developed symptoms of psychosis, it takes them a little while before they first seek help for this. And this first help could be from a school counselor, a GP, the emergency room. And there could be numerous reasons for this delay, everything from sort of the need to first identify what's going on, the need to feel comfortable speaking to someone about it, stigma, many other sort of reasons. And this initial delay is what we call help-seeking delay. Following this, and this is something very important, once they have sought help from somebody, it takes additional time and additional steps before they begin receiving appropriate care from a service provider or a service system that's equipped to respond appropriately to the needs of someone in the early phases of psychosis. So it could be, for example, that the school counselor takes some time before they recognize that this is psychosis, and then they may feel not prepared, and they may refer them to the emergency room, and then the emergency room then refers them to our service. So there's an additional delay within the system, which we call sort of the referral delay. And together, they comprise the duration of untreated psychosis or the entire treatment delay before someone receives appropriate services for psychosis. And I was kind of really, I was very surprised to see that the DUP is so high in France, and perhaps this is something we can talk about later during the day. What you can see over here is that in our case, the median duration of untreated psychosis is about 16.5 weeks. And while it's not insubstantial, it's much lower than the DUP that has been reported in several parts of the world. And I do think a lot of it has got to do with the work that we've done, particularly in terms of reducing the referral delay, although much more can be done in this regard. When you see these numbers in terms of DUP and delays and the number of weeks or the number of days. What it doesn't really capture is what it means to a young person and her or his family member as they seek help through the system. And what you see here is sort of a story pictorially depicted from one of the young people who entered our service. So this was a young person, 15 years old. Once they developed symptoms of psychosis, they first sought help from a school psychologist who followed them regularly without offering services for psychosis, clearly perhaps unable to detect that this is sort of symptoms of first episode psychosis. And then from there on, they go to the emergency room, one more emergency room visit, then to the primary health care, then to an evaluation service within a tertiary hospital, and then finally end up at our service. So it took this young person 15 days before they spoke to their school psychologist about experiencing symptoms of psychosis. And from that point onwards, within the healthcare system, it took them 1 year and 2 months before they finally ended up at PEPP. And this isn't very typical of the referral delay in our service, but it certainly does happen, and it happens in various parts of the world. And they made a number of contacts, about 6 contacts, help-seeking contacts, within the healthcare system. And this sort of systemic delay is really quite unacceptable. So what we often do, what these stories have helped us do, is in addition to doing very systematic outreach, we often do real-time early identification strategies. So in this case, for instance, we made a contact with the school psychologist, told them about our service, told them about how to refer, and since then have been getting direct referrals from the school psychologist to PEPP. So we've done a lot of research over the years, and this has yielded various insights on the extent of treatment delay, the number and types of help-seeking contacts, the various predictors or influences on pathways to care. And I do think that this is something that has helped us think better about organizing services. What we know, for instance, is that the median number of help-seeking contacts between the onset of psychosis and prior to entering PEPP is about 3, with a wide range from 0 to 14 contacts. What's also perhaps a little bit more disconcerting is that for about 40% of the people within the healthcare system, despite our continuous efforts to do outreach and assertive sort of early identification, they make about 3 to more contacts before they enter PEPP. So, and perhaps even more disconcerting is the fact that 50% of our clients, and this has sort of stayed the same over the last 10 years or so that we've existed as a program, is that they enter our service through first having entered the emergency room service. And this is more an indication of the Quebec healthcare system, where many people, particularly if they have mental health concerns, do not have access to a family doctor or a general practitioner or to the primary healthcare system. What we've also found very interesting is that being in contact with a family doctor or primary healthcare, while it does prevent you from getting into care through really traumatic pathways, like by the police getting involved or through ambulance involvement, what it does, it also increases DUP. And what this tells me is that we do need to increase capacity among primary healthcare providers to be able to detect psychosis and respond appropriately. We've also done sort of a more systematic study trying to reduce treatment delay and increase the number of referrals. And what we did in this is we really mapped out all the referral sources in our catchment area and showed them videos about psychosis and gave them sort of increase their capacity on how to refer, when to refer, and how we would respond within 72 hours. We also looked at what impact this intervention had by comparing it to a historical control period where we did not have such an intervention. And what we found was quite interesting. One, that we did manage to increase the number of referrals. We didn't quite manage, especially in terms of referrals that came from community sources, we did not manage to reduce treatment delay. And most patients still came from hospital-based sort of services. Perhaps our most interesting finding was that we had a huge increase in the number of referrals of people without psychosis, so non-cases. Now, what we noticed instantly is that these were young people who may not meet criteria for psychosis, but that they were very much in distress and needed clinical and mental health supports and services. And this kind of ties in later to some of the efforts that we're now doing within youth mental health. What we also found is that at times we weren't sure if it's because our referral sources were not able to differentiate between psychosis and others, or was it because they knew we would respond in a system that otherwise responds with huge waiting lists, that we would say yes, we would welcome them, and we would do an evaluation within 72 hours. Irrespective of the reasons, what we did notice is that we began to be really concerned that these were young people who were not going to be accepted into our service, but who nonetheless had very important needs that we weren't addressing. So far what I've really talked to you about is sort of the first component around reducing delay and providing, a quick access in order to be able to provide an engaging welcome into the program. In addition, the other important component, and I won't be able to talk to you in detail about it, is this idea of providing appropriate care that is centered in terms of philosophy on optimism, on recovery, flexibility, with a key emphasis on engagement and flexibility around engagement. And in our case, this model has tended to be focused around case management, along with other interventions that work around case management. So case management being sort of the backbone of the service, with a real focus on using community-based and not institutional resources. So this, again, we looked at a lot of evidence earlier, so I won't be going into detail, but this has now been the subject of several reviews and meta-analyses that show that early intervention compared to regular care yields better outcomes. This is certainly the case at PEPP as well. What we've also looked at, which maybe I do think it's worth highlighting because it's a sort of a personal area of interest in terms of making services acceptable and engaging to young people. And what we find is that about 76% stay engaged in care for 2 years. And I know it's not impressive after I heard yesterday that in Dr. Kunus's program, it's about 7% who disengage. But for an urban site and compared to regular care services, it is pretty impressive. What I like even more is the fact that we have about 70% of our family members are engaged and stay engaged throughout the 2 years, supporting their young family member. And this is very different from the picture for psychosis in terms of the relationship damage that it did years ago. We've also done a lot of work in terms of figuring out what are some predictors of outcomes. And I've kind of tried to summarize some of this in this slide. And it does, what we found is that achieving and sustaining symptom remission, particularly of negative symptoms, may play a larger role than cognition in determining social and employment outcomes. What's also important is the early course. So even within the first 2 years, the first 3 to 6 months seem to be very important in terms of predicting long-term course and outcome. So one of the questions that the field has kind of tackled in general is that we know that early intervention services work, and typically these services have been set up for about a year to 18 months to 2 years. One of the questions that emerged, particularly after the first OPUS study, was, would these effects, the effects of enriched care, stay after people are transferred back into regular care or standard care? So after the first 2 years, if they are transferred back to regular care, would the impact of these improved outcomes persist, or will they fade? So one of the things that we did, and we just sort of completed this trial, and we finished writing our paper, which is now accepted, is it was a major trial. It took a lot and what I am happy to say is that what we looked at was we compared, at the end of 2 years of receiving PEPP services, people had a choice of, they were randomized either to receive 3 more years, so 5 years of receiving specialized early intervention, or being transferred to regular care, which would have happened anyway. So people either got 5 years of PEPP or 2 years of specialized early intervention, followed by 3 years of services from a GP or a psychiatrist in regular psychiatry. What we found was some very interesting things, and perhaps like one of the things that I find quite interesting, which isn't really the main focus of our study, was that those who were randomized to receiving early intervention were much more satisfied with the results of their randomization, and those who were randomized to regular care were not, suggesting that they had really formed an alliance and a positive impression of the service that they had received services from. What we also found is that those who receive early intervention are much more likely to continue with the research follow-up, and perhaps not surprisingly, they receive a much higher number of interventions and stay in service for a much longer time than those who are transferred to regular care. So again, substantiating this idea that early intervention has much better service engagement results than regular care. What we also found, which was really our primary hypothesis, was that receiving extended specialized early intervention resulted in longer periods of positive, negative, and total symptom remission. What we've had for, and it's a bit more of a sub-service within our first episode service, which is the Clinic for Assessment of Youth at Risk. It's our high-risk service, and we started that in 2005. Just some very quick results from our CARE program. One of the first things before we started the CARE service, what we've been doing is really asking people about their early signs and symptoms, trying to find out what happened before people developed a first episode. So this is work that we do in our first episode psychosis program. And what we found is that more than half of those with a first episode of psychosis do have what you would call attenuated symptoms or symptoms that resemble an operationalized clinical high-risk state before they had first episode psychosis. So this is more work that we've done in our first episode, but kind of supports this idea of a clinical high-risk state. Within our CARE program, what we found is that our number of referrals have increased, and perhaps most strikingly, these young people report higher levels of stress and distress than even some of our patients with first episode psychosis, suggesting that there is a clear need for supports and services. So in terms of the last couple of slides, I wanted to talk to you a little bit about the future or challenges. First, for early intervention for psychosis. So I mentioned earlier that early intervention for psychosis has had a long history in Canada, and we now have several early intervention services in the entire country, but that still doesn't mean that all Canadians have access to specialized early intervention for psychosis. So there are many, many Canadians who would not have services that are either specialized or timely for psychosis. And part of what explains this is the fact that, I think Canada is very, very vast, so we have many, many remote communities, including many Indigenous communities where there isn't even basic healthcare system. So we will need to have some more innovative solutions in terms of making early intervention accessible to more Canadians. The other thing that is unique or perhaps important to understand within the Canadian context, and I know that part of the interest today was to explore policy and services and how those play a role. In Canada, although we have universal health care as a guarantee, the administration of health care is very much a provincial business. What that means is that provinces really vary in terms of what they choose to commit to and how much they commit to it. So in Canada, there's only 2 or 3 provinces that have policy and funding commitments specifically for early intervention services for psychosis. And in those provinces, you will see that there are many, many more early intervention services than in the other provinces. In general, and I think I won't, we do need a bit more innovation overall in the early intervention field in terms of e-mental health and in terms of also a stronger and more creative ways of engaging both service users and families and incorporating peer support, things that users seem to really advocate for very poignantly. Part of what I wanted to just perhaps end with is this idea very much going along the same lines of the presentation that Pat McGorry gave, which is that this is a movement that you see in Australia, you also see this in UK, that some of the people who've championed early intervention services for psychosis are also now championing a bit more sort of broader transformation of youth mental health services. And part of what explains this is this idea that this emphasis on optimism and timeliness and friendly care and making sure that care does address appropriately the needs, the developmental needs and the illness needs of this young population makes sense not only in psychosis but for broader youth populations. So what we find is that part of what also motivated us personally is some of our work over the years with early identification, where we found that no matter what we did with early identification, we always detected many, many young people who did not really meet criteria for psychosis, but who nonetheless had very important needs and a lot of distress. Part of it was also acknowledging this idea, the nature of psychopathology in youth, that the trajectories are not all linear, that there is so much overlap, and as we were looking at the staging model earlier, that it isn't that you can clearly predict where people start and how they will end. We also know that in Canada, just like in many other parts of the world, many young people do not seek help, or they do so after very long delays and experience poor outcomes. So in the last little while, what we've embarked on is Access Open Minds, or Access Esprit Ouvert. It's a pan-Canadian project. Currently, it's funded for 5 years by the Canadian Institutes of Health Research with joint funding from CIHR and the Graham Beck Foundation. And what we're doing in this pan-Canadian, through this pan-Canadian network is developing, implementing, and evaluating a transformation in the way young people between the ages of 11 and 25 access services and the kind of services that are delivered to them. And right now we're doing it in 12 demonstration sites all over Canada that really represent the diversity in Canada in terms of urban, rural, remote, Indigenous, homeless youths, youths who are looked after or under the state protection system, youths in the criminal justice system. So really trying to transform the way services are delivered to them, both through early identification and what we found worked within early psychosis, having an open referral, a guaranteed response within 72 hours, multiple portals of entry. We've now taken those lessons and applied them to the broader context of youth mental health. We've also really been one of the things that we've really worked hard is to eliminate this age-based transition at 18 to make sure that services are continuously delivered as long as people need up to the age of 25. And another sort of emphasis in this has really been a strong participation of youth in shaping these services in the way they're delivered and what's delivered, and both in terms of the actual context, the creation of these youth spaces, but also in terms of principles like shared decision-making and informed consent. So this is just beginning, and in the next few years, hopefully, we will have some results from this initiative. I'd like to just end by thanking the number of people whose work, including several of my students, that I compiled to present today. I'd like to thank the Access Open Minds and PEPP service users, families, and staff, and also definitely would like to thank my key sort of research colleagues, including Ashok Mala, but also Rida Jubair, Jay Shah, and others. Merci beaucoup.